the presentation and workup of patient with late onset hypogonadism, and Dr. Grobler from the University of Stellenbosch will be discussing the management. Thank you so much, Marinka. You can start.
Sure. Good morning, everybody. Just a quick overview of what we'll be going through, a quick history of testosterone, the definition of late onset hypogonadism, a quick review of the physiology of testosterone, how patients typically present, and then the workup and the take-home message. So testosterone, all through history, the link between testosterone and virility has been known. In 1849, Berthold transplanted testes from roosters to capons and noted that they regained their androgenicity. He then postulated the existence of a substance transmitted by blood as responsible for these observed effects. In 1889, Charles Edward Brown Sequard injected himself with a mixture of dog and guinea pig testes extracts, testicular vein blood, and semen, and reported miraculous revigoration. The rest of the medical community, however, did not jump onto that bandwagon and largely termed it poppycock around about 1927. Only in 1935 did Ernst Lackius' team succeed in isolating testosterone. Shortly thereafter, Buchanan and Ruziker individually synthesized testosterone, and they also won the Nobel Prize for this in 1939. The knowledge regarding testicular function in general and in advanced age were further aided by the establishment of radioimmunoassays to measure testosterone in 1972. And since then, copious amounts of research into testosterone level and its relationship to the aging male has been done. So the definition of late onset hypogonadism is a clinical and biochemical syndrome associated with advancing age, characterized by symptoms and a deficiency in testosterone. Previously had many names: male climacteric, male menopause, andropause, partial androgen deficiency of aging men, androgen deficiency of aging men. These days, most authors and guidelines have settled on late onset hypogonadism. However, our friends in America prefer the term age-associated testosterone deficiency. When we look at the physiology, just basically the hypothalamus secretes gonadotropin-releasing hormone, which stimulates the anterior pituitary to release LH and FSH. The LH then stimulates the Leydig cells of the testes to produce testosterone. Testosterone is synthesized from cholesterol, which is turned into pregnenolone, which is the precursor for most or all sex hormones. In the blood, testosterone is present in three forms: tightly bound to serum hormone binding globulin, free testosterone, and albumin in those percentages. So the bioavailable part of the testosterone is the free testosterone and the testosterone that's bound to albumin, which is weakly bound, which is why it's considered bioavailable. The classic classification for hypogonadism is primary, secondary, and then there's some target organ resistance, and then age onset hypogonadism. So essentially, when you have an issue primarily in the testes, you have primary hypogonadism, and when you have an issue in the hypothalamus or the anterior pituitary, it's termed as secondary. So the presentation symptoms, I categorize them into sexual and non-sexual as an easier way of remembering them. Mostly patients present with complaints about the sexual symptoms: erectile dysfunction, decrease in frequency of morning erections, low libido, and difficulty with orgasm, either achieving it or that it has a reduced intensity. Then the non-sexual, also you can call them cognitive and physical. They have a depressed mood, fatigue, decreased vitality, impaired memory and concentration, hot flashes, which is also a prominent symptom that they complain of, a feeling of helplessness, irritability, sleep disorders, and a decrease in physical strength. So most of these symptoms are vague and non-specific and may feature in a multitude of other conditions. Several screening questionnaires have been developed to aid in the detection of late onset hypogonadism, but their specificity is low for most of them, and overall they're not recommended for use by the EAU. A couple of examples are the ADAM questionnaire, which has a 97% sensitivity, which is quite good, but only a 30% specificity. The aging male symptom score, 83% sensitivity, but only a 39% specificity. And the Massachusetts male aging study has a 60% sensitivity and a 59% specificity. However, these may be useful in assessing the presence of these symptoms, as well as their severity, and when monitoring when treatment is started. So not specifically to identify late onset hypogonadism, but to establish whether symptoms are present or not. When you go to your history, it's important to do a detailed medical and sexual history, as well as to exclude possible causes for primary and secondary causes of hypogonadism. On the list here, you can see several causes of primary hypogonadism. I'm not going to go into detail about those, but it is important to know them so that you can exclude them. The same with secondary hypogonadism. And it's also important to look at diseases that can also decrease your testosterone, so that you don't diagnose a false low level of testosterone, if I can put it that way. The most notable of those are chronic obstructive lung disease, HIV, chronic kidney disease, liver disease, because it produces the proteins that carry testosterone, hypothyroidism, because it mimics a lot of the same symptoms. And then several drugs can also lower your testosterone levels, especially your glucocorticoids, opioids, and antipsychotics. And then any acute illness or recent surgery can also lower your testosterone levels. So it's best to rather wait until they've recovered from this before testing for testosterone. So on your examination, it's important to do a full general and genital exam, including a DRE, because most of these men will be older than 40. Focus should be on virilization, BMI, waist circumference, gynecomastia, and your testicular size and consistency. It's basically Michelangelo turning into Mike Jello, where they have an increased waist circumference with an apple body. They complain of baldness and increased body fat in areas where they didn't have them before, with a decreased muscle mass as well. In your investigation, I enjoyed the EUA guidelines. It's a nice, simple way to set out. They suggest restriction of the diagnosis of testosterone deficiency to men with persistent symptoms. And then a measurement of testosterone in the morning, usually between 7 and 11 hours, preferably in the fasting state. There is some controversy regarding this, where a high carbohydrate meal can reduce your testosterone. But the added benefit of doing it fasting is that you can do your fasting lipids as well as your glucose to screen for other illnesses as well. They suggest that if the testosterone is low, you then repeat your total testosterone with a reliable measure. They also suggest that you also measure free testosterone in men who have a borderline testosterone between 8 and 12. And if you suspect or there are any known abnormal sex hormone binding globulin levels. So they also say that you should consider assessing testosterone in men with a disease or on treatment in which testosterone deficiency is common. So those are many that we spoke of before. If there's any sexual dysfunction, type 2 diabetes, metabolic syndrome, which is very important, any pituitary masses where they've had radiation, and treatment with medications that also cause suppression of your testosterone levels, like we've said. Then HIV is also very important, and any men with a history of osteoporosis or low trauma fractures. The EAU also suggests that you do LH and FSH to help you differentiate between primary and secondary. In terms of LH, they suggest that you do it at least twice in 30 days. And if both your testosterone and LH is low, that you then also do a prolactin to exclude a microadenoma. So the trouble with testosterone is that the controversy exists regarding what constitutes low testosterone. The EAU recommends a total testosterone level of 12.1, as this is the lower end of the 2.5 percentile of population norms. However, the AUA prefers to focus on benefit to treatment that they've based on randomized controlled trials, and they suggest a testosterone level of 10.4. The EU then also recommends the free testosterone measurement in borderline patients, where the AUA does not recommend free testosterone measurement in clinical decision making, but they do give physicians leeway in certain select patients. So now, which tests to do for testosterone? There are several. None of them are perfect. If you look at the direct radioimmunoassays or the ELISA, they're simple, rapid, they're not very expensive. They have a fast turnaround time, but they're often over estimate the testosterone concentration. They're not standardized, and they have a limited accuracy below certain levels. When you look after radioimmunoassay after extraction and chromatography, widely used, well documented. You can look at multiple steroids in the same sample. However, they're labor intensive. They require a high degree of technical experience, and they also generate radioactive waste. The same with the microchromatography after extraction with liquid chromatography. They are the gold standard. You can also assess multiple steroids, and they're highly accurate, but very expensive. Their standardization throughout the world is also lacking, and they've got a long turnaround time. So there's no perfect test, and most guidelines recommend that you know the test that you are using in your local hospital, as well as your local reference ranges for your patients. A short note about serum hormone binding globulin and free testosterone. Serum hormone binding globulin is a glycoprotein synthesized by the liver. It transports testosterone, dihydrotestosterone, and estradiol. Testosterone has a higher affinity for serum hormone binding globulin than albumin. It's not considered a bioavailable form of testosterone because of this high affinity, and the measurement is suggested when testosterone level is borderline. Several conditions can alter the concentrations of the serum hormone binding globulin. The comorbidities that decrease it: obesity, glucocorticoids, nephrotic syndrome, hypothyroidism. Increase it, an important one for us is HIV, any liver issues, hypothyroidism, any estrogens, and anticonvulsants. So late onset hypogonadism is a little bit of a chicken and an egg situation. It occurs more often in men with chronic disease states that are more common with advancing age, such as obesity, diabetes, and this makes it difficult to separate the influence of aging with the influence of comorbidities. Depending on which paper you read, the testosterone level drops after the age of 40 from anywhere between 0.4 to about 2%. Research suggests that a high BMI, central adiposity, and metabolic syndrome are associated with a lower total testosterone. The question remains, however, whether the lower testosterone predisposes patients to these, or whether these patients are directly linked with lowering total testosterone. And research is ongoing to establish the causal relationship between these testosterone levels and these different comorbidities. And then lastly, in HIV, testosterone deficiency is more common in men with HIV as compared to the general population. The pathophysiology mechanisms are multifactorial. They have a poor nutritional status. There are several medications used that can alter the level of testosterone. In some patients, there's also an incidence of illicit drug use, including opiates and methadone, which can also alter your testosterone levels. They often have pituitary dysfunction and Hep C co-infection, as well as other opportunistic infections, which can give a lower level of testosterone. They also typically have increased levels of serum hormone binding globulin, which then decreases your bioavailable testosterone, and a low CT4 and a high viral load also predisposes them to lots of opportunistic infections. So the take-home message in terms of late onset hypogonadism is to have a high index of suspicion, especially in patients complaining of the sexual symptoms. You must exclude other causes of testosterone deficiency. It's critical that they must have persistent symptoms as well as a low testosterone. And then testosterone must be tested on 2 occasions between 7 and 11 a.m., preferably fasting. Free testosterone and serum hormone binding globulin will be helpful in borderline cases. Know which type of test your local lab uses, the pros and cons with the test, and the local reference values. And then exclude any other reversible conditions causing low testosterone. Thank you.
Yeah, thank you so much, Marinka, for an excellent overview of the late onset hypogonadism. Do you have any questions on the floor? Anyone who's got a comment? All right. I think you did highlight clearly in your presentation, Marinka, that late onset hypogonadism is usually a multifactorial sort of condition, and like you said, you need to exclude other causes and the workup, to further manage these patients. There's someone there. Question from Dr. Lonabo Goli from Gobeja. How long should the interval be between the two testosterone tests?
So again, it depends on which literature you use. Most recommend between 2 weeks and 30 days.
All right, thank you so much. I hope you're fully happy with that. Any more questions from the floor? Yeah, he seems happy. All right. Yeah, no, thanks so much.